All right. I am very happy to have as a guest today on Let's Chat Health Tech, Ben Gardner, who's the CEO of Vitalic. You can find them at vitalichealth.co, right,
You're right.
Ben? And Vitalic is a behavioral health company that's built specifically for aging adults. And they partner with Medicare Advantage plans and risk-based providers. And they're kind of very focused on going to the seniors themselves and engaging them and getting them involved in episodic engagement. With that, Ben, we'll get into this, of course, but welcome.
Well, thank you, Brendan. Good to be here.
Good to have you, man. And so behavioral health, I kind of teed it up a little bit, but tell me a little bit more about exactly what Vitalic's market is in more detail, and also what's your specific value proposition?
Yeah, great. So I would first start out by saying a couple of things about the problem at a high level. And, an interesting data point over the last 10 years, there's been over 10 billion invested in new behavioral health solutions, right? There's been a ton of innovation. COVID did a lot to kind of normalize and almost democratize behavioral health, really bringing access. Interestingly, of this 10 billion that's been invested over the last 10 years, less than 5% has gone towards the 65 plus population. Meanwhile, it's the fastest growing. In a few years, this cohort, 65 plus, will be larger for the first time in history than the 18 and younger. It's the most expensive population. And we see a lot of when it's time for, a child to need behavioral health, we'll endeavor to get them in front of a pediatric psychiatrist. This specialization is important because of the developing physical along with the mind. Those same dynamics exist on the other end of the life stage where you've got slowing metabolism of the aging adult, neurocognitive issues. They need a specialized behavioral health care. So first of all, we're bringing that. The other couple of issues that I would mention is 25% of this population has a behavioral health issue, yet 70% of them never get it treated. And referring back to my comment about COVID did a lot. The younger populations wear the fact that they've got a therapist on their sleeve, which I think is wonderful. But the 65 plus, not so much. The shame and stigma is through the roof. They will not avail themselves of care, nor are PCPs, unfortunately, referring enough. So we've brought to market a geriatric specialized practice, number
Yep.
one.
Yep.
Number two, we're not going to wait as every other behavioral health practice does for the member to call us, because they won't. We're going to partner, as you mentioned, with the Medicare Advantage plan or the at-risk provider to help them identify those members who likely have untreated behavioral health that's increasing total cost. It's creating problems. We get that file. We do the proactive outreach. We've gotten really good at building trust, helping to destigmatize this issue, and enrolling these members in this episodic based care model.
Yeah. So the way you got started, you're a relatively young company, right? The way you got started with the big deal for you that really kind of jump started the company was VNS Health. And can you spend a lot of this podcast is focused on how to get health tech companies into health plans and health systems. How did you get that deal going? What were the kind of the moving parts, and who was the champion, and what unlocked it, as it were? Can you spend a minute on that?
Yeah. So this is a little bit of an unusual case in that I was actually approached. I was working on a similar model at the company where I was leading growth before this.
Yeah.
And an investor approached me to see, they had an idea basically for Vitalic. And they approached me if I would be interested in being CEO in launching this. And the investor kind of came with a package with VNS Health. That VNS Health was also looking into doing something like this. So, I mean, at some level, this was a kind of a served up on a silver platter. If I'm being honest, I've done, kind of launched businesses out of the gates on my own. This was kind of fortuitous.
Had a head start, but still. So who is the champion on the VNS side? I mean, not the name necessarily, but like what sort? Tell me a little bit about. Use that as an example of like the pain points. Who are the people that are involved? And I always talk about how to triangulate and get breadth inside of a sales or opportunity. And so, how did that play out with VNS?
So VNS has an investment arm
Yep.
for starters, and
Yep.
certainly one of the champions there was the head of their investment arm. But then on the organization itself as a payer and a provider, they're both a payer and a provider. The CEO of both organizations appreciated the impact that untreated behavioral health was having on VNS, particularly as a payer, that it was driving unnecessary ED utilization. It was worsening quality scores. They were leaving risk adjustment revenue on the table because this population was really hard to engage because of the shame and stigma
Yep.
associated with behavioral health. So
Yep.
we had support in the C-suite, but then also with leaders from quality, total cost of care, head of their Medicare product. It was really a kind of a match made in heaven, if you will.
Yeah. And so who's doing the selling today for Vitalic?
So we are just over 2 years old,
Yep.
and so it's really founder-led sales. I mean, I've got, my background is largely in growth, and so we're in the middle of signing our 5th contract right now. So I think we're starting to show that product market fit, but, obviously there's a lot of benefit to making sure, we're still learning. And so I think having that founder-led sales is making sense, but we're also getting to that tipping point where we've got to start creating some capacity on our end.
Okay. That makes sense. That's very typical, and it'll kind of free you up to do kind of more of the strategic sort of stuff. And then that makes sense. Before we started, before we kicked things off, you and I had a chance to chat about this conversation, and we were talking a little bit about when you sell to a health plan, you have to be aware of things at a very specific level. You have to be able to communicate to them in the terms and the metrics and the priorities that matter to them, right? And so you can't just go in and just talk about, hey, I have this solution. You have to explain the solution in the very specific terms that will matter to them. So with that in mind, the question is, I guess, when you sell into a health plan or a risk-bearing entity like an ACO, what are the messages that particularly that you focus on? Stars? Is it the chief medical officer's office? Is it care management? Is it what are the kind of messages, and do they differ by how do they differ by department or job or role?
Yeah, great question. And I would first start by saying, you said something at the start of this, and this is, you could have a solution that clearly would provide value to a payer, but have you solved in advance? Does it rise to the level of it? Can it become a priority?
Yeah.
Is the what you want to charge for, can it be justified? There's a lot of companies, as you know, that have kind of come to market with a really cool idea, but the founder of the organization hasn't really run through, is this rising to a pain point where you can get a payer to move and an ROI? And so we've demonstrated, and certainly there's enough data out in the market today that shows that untreated depression
Yes.
is wreaking havoc, particularly in this 65 plus population. So when you look at members who've got congestive heart failure, diabetes, hypertension, they're already more expensive. And there's a ton of literature that shows when you layer on depression on top of that, or even anxiety, if you've got a diabetic, they're less likely to keep their A1C in check,
Right.
et cetera.
Yeah,
So they end
sure.
up in the emergency department.
Yeah.
What makes, I think, what we're doing unique as a behavioral health practice is most outpatient behavioral health practices, their value proposition to a payer is, look, I'm going to improve your members' depression. Depression is measured via a score mechanism called the
PHQ-9.
PHQ-9.
Yep. Mm-hmm.
And so if your value proposition to the MA plan is, look, I'm going to improve your members' PHQ-9, that's wonderful. Let's say you do a good job of lowering the average PHQ-9 from a 20 to a 10. That's success. Unfortunately, the CFO, the payer who owns the pocketbook, has no idea what is that worth. So what we're doing is we're not competing. While we are improving that PHQ-9 or the GAD, we're finding outcomes that are really valuable that we know the payer will pay for. And that's, we can reduce ED utilization if you treat this. We can also pick up risk adjustment codes, which are really important, that enable the Medicare Advantage plan or the ACO to be paid more for the member because they're sicker appropriately. And then we also are helping them from a quality perspective meet certain quality measures. Those three areas, quality, cost, as well as, risk adjustment, there are three kind of buyers where we're creating really measurable value.
Yeah, and this is a message that I spend a lot of time communicating, and that is that when you're, as I said, when you're selling into an organization, you really have to sell very, very specifically about what it is that matters to them, and that can matter differently from job description to job description somehow, and you have to triangulate and get those various opinions to matter and collaborate. And the example that you brought up before we started is with risk adjustment and on the stars rating, that you actually discovered that there was a new stars metric that kind of helped, and that helped you in your business argument. And my guess is you probably educated your customers along the way that they were probably not even aware necessarily. Is that true?
I think some people within the payer organization weren't aware, but like this new measure that you're referencing, a depression screening and follow-up measure, was announced about 4 months ago. The folks in quality are well aware of this as soon as it hit.
Okay.
It is a massive pain point. It's truly a massive regulatory tailwind for us. It was as if CMS created this measure for us. We, started the company 2 years ago, but I do think what a lot of people don't know, to your point about the risk adjustment, where we are educating some people in quality, the way the new quality measure works, all MA plans have to screen everybody for depression. And then those who have a PHQ-9 of 10 or more need a follow-up within 30 days. So that's the kind of quality measure that we can help. What's interesting is, back to this risk adjustment piece, there's a code in HCC 155. A PHQ-10, if you have a PHQ-10 or higher, is the baseline to qualify for the HCC 155. So when we're outreaching to members and we're screening them, if they have a PHQ-9 of 10 or higher, we do the follow-up, checks the box on the quality, but then this member is also qualifies for a risk adjustment bump, which we can pick up. Yeah. And then by chance, if this member's had a few ED visits over the last year, likely caused by this untreated, there's a third bucket of value that we're picking up. And there is some education, particularly to the people in quality who aren't thinking about impacting total cost of care or risk adjustment necessarily.
Yeah. Yeah. That's exactly the kind of the level of detail, I think, the kind of level of understanding of the marketplace and the business model and the opportunity that I think really can make a difference. And is there a penalty if they have a score above 10 and they've got to get a follow-up within 30 days? Behavioral health being slammed with, just so resource underserved, as it were. Is there a penalty if they don't get the
100%?
Yeah.
Yeah. So the way, as all star measures, you've got the denominator and the numerator, right, and there's going to be a benchmark that you've got to hit that will impact what your star rating is within this certain measure. And that's made up of both the screening, what percentage of members have you screened?
Right.
And then of those that have a 10 or higher, that have had the follow-up. And payers are going to suffer. It's going to be to the point that you mentioned. We don't have enough capacity, behavioral health capacity, number one. But number two, even if an MA plan has some kind of relationship with a behavioral health practice that has capacity, these members themselves loathe behavioral health. So you tell a 75-year-old, hey, you scored positive, we're going to get you referred over another practice. And this is what we excel at. We understand how to engage and communicate around these issues with this population and build trust and reduce this shame and stigma.
Yeah. Okay. That's as I would have thought. So that makes sense. You're actually also helping to solve a problem at that level. You go to the trouble to diagnose somebody, and that's relatively painless to do. PHQ-9 is very easy to complete. And then at the end of it, boom, you're scoring above 10. Now you've created the health plan has a new problem they have to resolve, and you're coming along and helping to resolve that as well. That makes a ton of sense. Yeah,
And I
that's
think there's I don't know if it's a dirty secret or whatever, and this isn't across the board, but that very dynamic of what you just mentioned, like you've
yeah,
diagnosed it, now you have to do something about it.
yeah,
PCPs, not all PCPs, but a lot of PCPs like almost don't want to do the screening because if
yeah,
they find out there's a diagnosis, they have to
yep,
do something about it,
yep,
and they know that they're kind of handicapped in doing something about it.
right,
So
absolutely.
this is a really important issue that isn't really being addressed for two reasons. One, the healthcare providers aren't digging into it because they're afraid of what they might find, but the members themselves, because they loathe this issue, also
Yeah,
aren't engaging. And meanwhile, it's
yeah,
costing the US health system and Medicare
yeah.
billions of dollars a year.
Yep, yep, understood. Like a classic question I like to ask it, or is it well, like what's the single biggest level of resistance when you go to talk to a health plan or a risk bearing entity? Like what's the big obstacle or the big objection that you have to overcome?
If I can give two, it would be one, and if there's any kind of early stage entrepreneur kind of listening, you can have the greatest value proposition and an ROI that truly is good.
Yeah,
You've got to have an appreciation that over the last 10 years, and you know this well, Brendan, the number of companies that have come to market across all kinds of different kind of healthcare
yeah,
segments
yeah,
is staggering.
yeah,
And I have sympathy for the buyers at MA plans and ACOs. They're being bombarded with folks like us.
yes,
Even with an ROI, it's
yes,
still their heads are on a swivel. So the first thing is, can you cut through this blizzard of noise and have an appreciation that it's going to take a little bit of time to be able to get somebody's attention? Number one. Number two, I think for us specifically, because at the start of this, I mentioned there's been billions invested in behavioral health over the
yeah,
last 10 years.
yeah,
Most of them don't have, frankly, a great ROI for the payer. And the payers have seen a lot of outpatient utilization and spend go up, but
yeah,
there's not been an ROI.
yeah,
So a lot of payers are a little reluctant. They need to make sure they have network adequacy, but they're
yeah,
not going to say this publicly.
yeah,
And so when we present as a behavioral health practice, sometimes it can be, oh gosh, not another one. But we're willing to put some of our fees at risk. We don't want to just be valued at, are we improving the behavioral health outcomes? We really are talking about total cost of care, risk
yeah.
adjustment, quality. Those are a couple of the biggest kind of headwinds that we face.
Okay. There's a quote that I think is attributed to Reid Hoffman that I really like, which is, as a leader of an organization, you have to figure out which fires you let burn. And and I think as a salesperson, as a health tech leader that's trying to get into a health plan, you have to figure out a way to communicate that this is not something that you can afford to let burn, or it's relatively effortless to put out, comparatively speaking, because there are a lot of things they'll just, to your point, they're overwhelmed by so many options and so many things to do. So what are the things that we can make an impact on, and do so because the vendor is doing most of the work and the risk is low and so forth. Right. So as we kind of wrap this up, like I'm kind of take a step back and AI comes into the picture, of course. And so how are you specifically leveraging AI in your solution? And that's the first question. And just how is that manifesting itself? And then secondly is, where do you see the industry and health plans going? And I'll share with you where I think some of the things that could happen in the near future. But I'd love to play this game with you if you could. Tell me a little bit about how you're using AI now, and what do you see the landscape looking like in, say, 5 years, 10 years?
Yeah, and I will share this, and I feel I want to share that I've got two co-founders, one who leads our whole clinical model, which I'm really fortunate to have a co-founder who's a clinician that's really driving that. And then we also, around AI, we've got another co-founder who leads product, who's got 15 years of 0 to 1 kind of behavioral health tech experience and a lot of AI. He's based in San Francisco. So he's really been driving the bus on this. I'm fortunate. But to answer your question, I mean, there are three things that we really need to do well if we're going to win here at Vitalic. We need to engage this hard to engage and reach population.
Yep.
We need to improve outcomes.
Yep.
And then we need to prove that we can show that the Medicare Advantage plans and ACOs will buy us. We're using AI for all of those three North Stars. So engaging members, we are using AI. So we've got an agentic voice agent that has been, we have an AI platform that's fine-tuned for this 65 plus population. And so we are using humans to do outreach, but we're also now using agentic AI for outreach. I believe we may have the largest kind of data set of 65 plus behavioral health data out there. And we're using this to inform our agentic AI to improve our engagement and reach rate. We're also now using AI within the clinical practice where certainly we're using it to make sure that we're, reducing no-shows as kind of appointment reminders. We're using it to help eliminate administrative issues for our clinical team from a note-taking, etc. I mean, there's a lot of ways, and now even within our OpEx organizationally, it's not just the practice, but how are we deploying AI? And we're using, really kind of creating this orchestration layer, which we couldn't have done 2 years ago. We have our own, really purpose-built CRM, EHR that has been built and serves us specifically well, again, that we couldn't have done 2 or 3 years ago, and we're doing so because of AI.
It's going to be tremendously disruptive in certain areas. In other areas, the jury's out. But for operational efficiency and in being able to do things at a very different scale, it's going to create some real disruption on health plans. And I think there's the real potential I think health plans are at risk of existence. I mean, it's an existential risk for health plans because I think good hospitals and care delivery mechanisms, anyone that's got a good care delivery model can probably drop a health plan component and do insurance. I'm not saying everybody, but I really wonder if there are entities that are big, that are really kind of savvy, will just start to pile on of all the other components that a health plan does and do so as they deliver care. So I wonder if, I would almost think that you're enabling technology, arms dealer, if you will, to hospital systems that have a health plan, right? And because they have behavioral health in there, but they need they need the automation that you folks offer to really scale and become meaningful. Because right now, there's a number of hospitals that have health plans. Baylor Scott and White, they're Indiana, and so forth. But they oftentimes serve just their local community, and oftentimes maybe even just their employees. I don't think it's that hard to imagine a large hospital system having a really robust insurance plan. And it would seem to me that you would dovetail right into that.
Yeah, it's interesting when you first asked that question. I'm like, that's above my pay grade. But when you said what you said, I realized I was just mentioning this to somebody like last week, that to be a payer takes deep, deep, deep pockets today, as well as deep, deep, deep regulatory kind of risk, kind of intelligence, right? There's a lot of deep, deep, and so the cost of entry is enormous.
Yes.
But I think, and my point was what you just said, I do believe AI is going to kind of democratize what has historically been like this scarce resource.
Yes.
And I think I would argue you're right that provider organizations, we're certainly seeing it, but like how I could certainly appreciate and see that AI will spur this kind of ability for providers to be able to more intelligently behave like an insurer and take risk like an insurer. Right.
I think there's going to be a big I can't help but think there's going to be a big roll up of hospitals. Like some of the big brands will just continue to buy up hospitals. And when they do, they can then become an insurance plan, right? For a larger and larger organization. And I don't know. I wonder. It's anyway. I'm going off on a little bit of a tangent, but I do think it's going to be a very disruptive time in that regard.
Well, Kaiser's kind of figured things out in a pretty positive way, right?
Yeah.
Like,
yeah.
I think there are some of these kind of providers that are showing, there are some benefits.
Yeah, they should be able to do cost takeout. And, Ochsner down in Louisiana is doing some very innovative things. On the payer side, Oscar Health is really kind of a very interesting kind of a solution, and they seem to be thinking, you know, very strategically. So, at any rate, just thanks for that. So, wrapping up, man, anything like, if who should reach out to you? Like, what sorts of, if anyone that's watching, listening to this or watching this, how should they contact you if they, if and why?
Yeah, I think anyone who is part of a risk-bearing organization of, the 65 plus population, whether it's a, an MA plan, a duals population, an ACO that is, appreciates that they may be the work that they're doing may be impacted adversely by this untreated behavioral health, would love to talk to them. And they can, my email is bgardner at vitalichealth.co. I'm on LinkedIn. I'm happy to
That'll
give
be in
my
the show
mobile
notes.
number, my home
Yeah.
address. I'm a equal opportunity.
So, anyway, well, Ben, I really appreciate it. As always, it's great to chat with you, and thanks for this. This is fantastic, and I wish you continued success with Vitalic. Okay.
Thanks, Brendan. Appreciate it. Enjoyed it.